Hello everyone, my name is Andrew Saglov and I'm an internal medicine resident at Springfield Memorial Hospital in Springfield, Illinois. Our clinical vignette revolves around a rare complication of an otherwise very common medical problem, vitamin B12 deficiency. Vitamin B12, or cobalamin, is a water-soluble vitamin primarily found in animal products, such as red meat and dairy. When consumed, it is primarily absorbed in the terminal ileum of the small bowel, where it functions as a cofactor for enzymes in DNA synthesis reactions. B12 can become deficient in vegetarians or when antibodies develop against intrinsic factor, a protein that facilitates the absorption of cobalamin in the small intestine. This latter process is termed pernicious anemia. In rare cases, the effects of B12 deficiency may extend to the bone marrow and impair production of red blood cells. This leads to the destruction of erythrocytes faster than they can be produced, otherwise known as hemolytic anemia. Our case centers around vitamin B12 deficiency, secondary to pernicious anemia that mimics hemolytic clinical features. Our patient presented to the emergency room with a 1-week history of progressively worsening epigastric pain and generalized weakness. Her symptoms began 2 years prior, but she never sought medical attention because the pain was mild. On admission, her vital signs were normal. She was hemodynamically stable and breathing comfortably on room air. Physical exam was largely unremarkable, with only mild tenderness to deep compression in her epigastric region. She denied excessive alcohol use and endorsed a balanced diet with multiple servings of meat and dairy each week. A CT abdomen and pelvis without contrast did not show any acute findings. Initial labs showed a normal white count, a critically low hemoglobin of 6.1, her baseline being around 12, an elevated MCV of 125, and a normal platelet count of 196,000. Her corrected reticulocyte count was 0.178%, indicating underproduction of red blood cells. Iron studies were normal. A peripheral blood smear revealed macrocytic cells with minimal anisocytosis, or low variation in the size of her red blood cells. No schistocytes were noted on the smear. This is where we need to make a clear distinction between macrocytic and megaloblastic. In the clinical images section, the image on top shows macrocytic cells, or cells greater than 100 femtoliters. The degree to which MCV is elevated helps to differentiate megaloblastic from macrocytic anemia. This threshold is important to consider because the inhibition of DNA synthesis during erythrocyte production primarily occurs when the anemia is megaloblastic in origin. An MCV greater than 115 is specific to megaloblastic causes, primarily seen in folate and cobalamin deficiency. This is seen in the image on the bottom, with the arrow pointing to hypersegmented neutrophils, or neutrophils with more than 5 nuclear lobes. Going back to the case, follow-up studies revealed a haptoglobin less than 30 and a very high lactate dehydrogenase over 2000. This was consistent with active hemolysis, while a negative Coombs test ruled out antibodies on her erythrocytes. Additional workup showed a critically low vitamin B12 level of less than 50 picograms per milliliter and an elevated homocysteine level. Antibodies to intrinsic factor were positive, consistent with pernicious anemia. She was transfused with 1 unit of blood and received an intramuscular injection of cyanocobalamin. Over the next few days, her hematological indices improved, and she was discharged with instructions to self-administer cobalamin once a month for the next year. The treatment resulted in complete resolution of her abdominal pain, and she currently gets weekly intramuscular B12 injections. In summary, this case presents a very important clinical lesson pertaining to lab values associated with B12 deficiency. When this patient initially presented to her outpatient clinic with symptoms, her MCV was in the normal range. This is most likely why a workup for cobalamin deficiency was not pursued. Hemolytic anemia often presents as a normocytosis and prompts a workup for toxins, medication history, hereditary causes, and recent infection. However, a B12 deficiency is often overlooked because the MCV may be normocytic. We suspect ineffective intramedullary hematopoiesis secondary to hyperhomocystinemia from cobalamin deficiency caused her anemia. In vitro studies have demonstrated that the buildup of homocysteine due to B12 deficiency increases hemolysis due to oxidative damage. In severe cases, patients may present with symptomatic pancytopenias that can be challenging to diagnose since they can mimic dysplastic processes. Healthcare providers should be vigilant for reversible causes such as B12 deficiency when working up an anemia, since lab values don't always fall in the range normally seen in the literature. Thank you all for your attention.